Good afternoon, everyone, and welcome to the late spring meeting of the Health Policy Commission. I want to welcome everyone and start off with approval of the minutes for April 14th. As in the past, we need to have each individual commissioner needs to approve it. So I'm going to turn to our maestro of all this stuff, our Associate Administrator, Executive Director, Colleen Ostermeyer. Colleen?
Absolutely. So we'll call first for a motion on the minutes.
So moved.
Second.
Second. Thank you so much. And then I'll call you all by roll call, starting with you, Mr. Chairman.
I agree. Accepted.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Kreider. I know he was audio only, so we'll pause for that. Commissioner Mastrogiovanni.
Aye.
Commissioner Roeder.
Aye.
And Secretary Sutters.
Aye.
Thank you.
So is Chris around, or what's he?
He was going to be audio only for the first 30 minutes, so I think he'll just be joining us in a bit.
Okay, well, we have everyone who was here approves it, so we could go on, right?
Yes, absolutely.
All right, so I'm now going to turn it over to David Seltz, our Executive Director.
Hi, good morning, everyone. Good morning, commissioners and members of the public. I'm very pleased to be here with you today for a jam-packed meeting. I'm going to turn it directly over to our Deputy Executive Director, Colleen, who's going to walk through the Executive Director's report this week.
Oh, sure. Thanks, David. Thank you so much, Mr. Chairman. We have a packed agenda today, so we're going to get right started. Just wanted to give a quick preview and highlights of what we're going to be asking our board to do today. Very excited to present final publications on a number of fronts. The first half of the meeting will be focused on our investment programs in care delivery transformation, specifically two innovative programs focused on improving the quality of prenatal and maternal child care for specific populations in Massachusetts. And then the second half of the meeting, we're going to pivot to our research work, including presenting research data on income and affordability, which will be a chapter in the upcoming cost trends report. Finally, we have a presentation on a study mandated by the legislature. Actually, at the beginning of this year, the HPC was asked to examine whether Massachusetts should join 35 other states in an interstate compact on nurse licensure, which allows nurses to practice across state lines with oversight. So that will be discussed by our board and released following a vote of commissioners today. And then finally, we're also going to return to the performance improvement plan process and begin that review for this year with the new updated list of referred confidential entities from CHIA, from the Center for Health Information Analysis, our sister agency. So that discussion will be at the end of this meeting, and we will be entering into a private executive session for that. Finally, I just want to let our board members know that we do have 5 votes on the docket today, all of which must be taken by roll call vote. So we'll move through those as expeditiously as possible. We did the first order of business in the minutes today. Mr. Chairman, if I may, I'll just proceed through to the rest of the slides. If we could go on my first slide for recent publications. Thank you so much.
Yes.
Great. Thank you so much. Just a really few high-level agency updates to share with you all. This year, we've released a number of publications, the biggest being the recent COVID-19 impact study, which we discussed at length during the last board meeting in April. Just a few others that I'd like to highlight. We released a case study on how Hebrew Senior Life adapted their Shoe Care program in support of their residents during the pandemic. We also published 2 programs. Pardon? Sorry. We also published 2 program briefs last month. The first on the Targeted Cost Challenge Investment Program. This is known as TCCI, which supported initiatives with innovative care delivery and payment models to reduce the cost of care and improve quality. And then the second brief was on the Neonatal Abstinence Syndrome Investment Program, or NAS, which supported initiatives designed to improve care for infants with NAS and for women in treatment for opioid use disorder, both during and after pregnancy. And you'll hear much more about this program and our work in this area later in the agenda. In January, we released a sustainability guide based on experiences from Healthcare Innovation Investment Program awardees, which include both TCCI and NAS awardees that successfully sustained their programs beyond the HPC funded period. I know sustainability is something that our board cares very deeply about, so we did publish those guides. And then last but not least, we released our Office of Patient Protection's annual report earlier this month. And all of these publications and much, much more can be found on our website, mass.gov/HPC. And on the next slide, we have a ton of exciting content slated for release throughout the rest of the spring and summer, some of which we'll be discussing later in this meeting. So here, I'm only going to highlight one. There's a lot of interest in this space. The upcoming next installment of HPC Data Points. We're going to identify trends in avoidable dental emergency department use in Massachusetts between the years of 2017 and 2019. So that'll be coming out in the next month. And then finally, I'm happy to announce the always highly anticipated annual healthcare cost trends report, which includes policy recommendations on key topics. That's slated for release at our July board meeting, so July 14th, 2021, and more on a specific chapter for that report later. And then finally, my last slide in the executive director's report, I just wanted to give a quick update on our health equity and diversity, equity, inclusion agenda at the HPC. As you know, our agency has committed itself to bringing issues of health equity and racial justice to the forefront of everything we do. And today, I'm just going to share a few updates on this work to integrate equity practices and principles into all of our work streams. Our staff has spent several months actually developing a health equity practice and style guide, which has been rolled out and is in use internally across our agency. This guide helps us to be more intentional in our writing and research and encourages reflection as we communicate about equity within our work streams. It provides HPC specific use cases, resources, and tools for staff to engage with as they pursue research and writing projects. So we're so proud to be able to apply it to all of our work, and it's already really making a positive difference across the agency. On the second bullet, the inclusion of race in the social determinants of health in our work is going to be even more prominent in this year's cost trends report, as well as the market transactions that come before us. This is already something that we've started doing. Would also add here that we're continuing to finalize and shape our agency-wide health equity framework into an implementation plan, which includes agency-wide metrics and goals. And we've been holding internal and external conversations on aligning available data sets related to health equity. This is an ongoing work stream that all the teams at the HPC are engaged in. One of the major goals of the framework is to help us address gaps in what data sources are available to us. So we'll definitely have more to come on this at future meetings. But finally, at today's meeting, we're thrilled to launch a new investment program called Beside. It's birth equity and support through the inclusion of doula expertise. In a few minutes, you'll hear about how this program will seek to address racial inequities in maternal health outcomes through enhanced or new doula services for Black birthing people. And this is an entirely health equity focused grant program. And not on this slide, but before I do hand the baton over to my colleagues, I just wanted to highlight our latest DEI internal agenda. We're continuing to provide workshops for staff, as well as opportunities to gather as an agency to discuss and center issues of race, issues of racism, and ensuring we have and maintain an equitable workplace. For example, last month we participated as an agency in YW Boston's Stand Against Racism campaign. We've also been working with our consulting partner, who I've mentioned many times before, Diversity at Workplace, to develop learning opportunities for staff. These include, we've done a number of them, but we have upcoming workshops on microaggressions, how to be an active bystander, how to be an ally, as well as a workshop on inclusive leadership. So I'm happy to report back to the board after we've conducted these workshops. And then one note on hiring, we're applying what we're learning and have already implemented changes to our hiring practices, and we have not done a lot of hiring of staff during the pandemic, but we did recently select and hire our 2021 cohort of summer fellows. And we made several changes to that process in order to identify and reduce our own bias. For example, we did things like we redacted names, we redacted schools and universities, we eliminated post-interview interviewer debriefs, which are all things that it can increase your own bias. And we've adapted all of these changes and implemented them in our future employee recruitment and hiring process as well. So I'll make sure to have our fellows make an appearance in some way virtually at our summer board meeting, so you can meet them all. They're all incredibly impressive and talented folks. We're thrilled to have them. Okay, that's it for me. I'm so happy to take any questions or comments that anyone has. Mr. Chairman, of course, please feel free to offer any additional thoughts.
All right, well, let me turn it over. Any comments or questions from the commissioners? This was great, and
Thank you.
yeah, no, the reports have been great, and we look forward to the ones that are being done.
Thank you.
Colleen, I'm just, the way, how seriously you're taking the health equity stuff is just fantastic. Thank you for doing that.
Thank you. It's an agency-wide effort, truly. Thank you so much. Okay, Mr. Chairman, if I may, would like to turn the agenda now over to your colleague, Commissioner Blakeney, to introduce the next set of agenda items.
All right. Barbara, you got to unmute yourself.
There we go. Thank you, Stuart, and thank you, Colleen. I'm very pleased to introduce this next section of our agenda. Part of our work is to find innovative ways and support innovative ways of getting better outcomes at less cost. Our care delivery transformation program focuses on this, and we have two very exciting initiatives to present to you today. One is a follow-up of a program that we have already done and will continue to support, which has some very interesting and positive outcomes. And the second one is a brand new program introducing the whole concept of doulas into care, especially in minority Black communities. And so without further ado, let me introduce our leader in this effort. And Kelly, let me turn it over to you.
Thank you very much, Commissioner, and good afternoon to the Board of Trustees. So you might recall at last month's board meeting, we shared recommendations for our C4CEN investment program. I noted at the time that C4CEN was built upon other HPC investments in promising care models for mothers and infants experiencing the effects of substance use disorder, opioid use disorder in particular. Today, as Commissioner Blakely mentioned, we're going to share findings from one of those programs, our neonatal abstinence syndrome investment program. Could we advance the slides, please? Which was a $3 million investment in 6 hospitals to support new evidence-based interventions and emerging best practices for mothers, families, and infants affected by opioid use disorder. Specifically, those programs aim to do 3 things, which we will explain shortly. One is increase non-pharmacologic interventions. The second was to optimize pharmacologic treatment for infants with neonatal abstinence syndrome. And finally, to increase access to services for both mother and infant after discharge. So as Commissioner Blakely said, the program delivered impressive results, which my colleague Rachel Applewhite will share with you shortly. But I will say graphs and charts and data alone really cannot do justice to the incredible work of the awardee hospitals or the impact on patients and providers. So we hope that this short video will help tell a more complete story of the NAS investment program and hopefully inspire you the way it's inspired us.
NAS is neonatal abstinence syndrome. It's a condition newborns can experience after they are born to mothers who have used opioids during pregnancy. Traditionally, NAS was treated as a withdrawal syndrome. Much like adults who withdraw, a treatment would be to provide opioids to treat the withdrawal symptoms. So once you start on opioids, that committed you to a length of stay of 10 days to 14 days. Often it was 3 to 4 weeks.
Women would come in and have a baby and be discharged 2 days later, and they were not allowed to stay with their child. They would have to come back and visit.
The Health Policy Commission's NAS intervention program recognized early that there could be a better way to care for these moms and babies.
A huge part of our program is focusing on the non-pharmacologic care, which in some cases is enough to get babies over that hump of withdrawal so that they do not even need pharmacologic treatment. Doing things like rooming in with your baby. So as simple as staying in the same room so she can care for her baby when he starts crying, to have the lights nice and dim to reduce that stimulation, to swaddle babies up tight or have babies skin to skin, which really has been shown to not only calm babies, but really promote bonding with moms and their child. We really try to encourage breastfeeding. We have amazing lactation consultants that can help with that as well. Physical therapy and occupational therapy come in and meet with the families to teach them about soothing techniques as well as infant massage, so it's something they can do even after discharge.
And that's really what non-pharm care is built around. It's care by the family, not care by medicines.
Before we started this, over 80% of babies were admitted for treatment. By treatment, I mean getting medications like neonatal morphine solution to address withdrawal symptoms. That number has dropped to less than 50%. Babies need their parents. It's quite simple. I think part of the reason that we probably had an 80% treatment rate was we made the moms go home at night. Of course that baby's gonna have more symptoms. Babies love touch and smell and warmth. And all of those are things that maybe seem subtle in some ways, but can absolutely have a huge impact.
The 6 hospitals that partnered with HPC on this initiative, they achieved real improvements in outcomes for moms and babies. So a 50% reduction in the number of opioid-exposed newborns requiring pharmacologic therapy for NAS, a 50% reduction. A 33% reduction in length of stay. So these babies were staying in the hospital 1/3 less time than they were before. And a 30% reduction in the need for care in a special care nursery or NICU.
The most important thing that we did on the inpatient quality improvement piece for the NAS initiative was to require trauma-informed care training of all of our maternal newborn services, physicians, midwives, nurses, staff, administrators. That made a critical difference.
There's a stigma that exists around moms in recovery, trying to be in recovery, moms on an MAT program. I myself gave birth on an MAT program where there was still a lot of stigma and judgment around that. And you would think that there wouldn't be, where it's such an epidemic here in the state. But you could still tell, and other people, sometimes they don't see the women on the other end of it, right? Like they only see them at their very worst. They only see them at their absolute darkest moments in crisis. They might not see that people actually do recover and are doing well and being productive members of society.
And I think if, as a staff member or a doctor, that you can understand how they got there, or at least understand part of the trauma that they've experienced and can be compassionate to that and have an open discussion to help moms in their sobriety and also help their babies to kind of get through any withdrawal they may have. Being able to have that trust and that open dialogue has been extremely helpful.
The impact that this initiative has had on hospital staff, on those of us caring for these moms and babies, it's dramatic. And I think it's largely driven by partnering with families. Another important part of this project at the hospital level, at the collaborative level, at the state level, is getting parents, getting families to be part of our teams.
They've kind of built a community with us, with themselves. And in that first year of the baby's life, it's so very important for them to build that up and realize that there are people who they can work with, and trust as, a doctor, a social worker, a recovery coach, and people that they can go to in a time that they're in need or that they're in crisis.
As a healthcare provider, as always, we want to be taking the best care of people that we can. And when we recognize that there is a need to change, then we have to have change leaders. And I think we just hit the right moment in having the right people and the right opportunity through the NAS initiative to be able to make those changes.
almost every single one of the moms have said, I just want to be a normal mom. And they just want to have that experience. Having this program at our hospital has given a lot of women a chance, and they were able to really turn it around and change their life so that they can parent their child. And it's been absolutely amazing to see.
For me, that is a success when they take that baby home. And it's amazing what that can achieve. And when you empower women to be able to do that, that's a game changer.
Okay, I think you're going to have to start my video from your end because it's not starting here. But you've seen my face well enough and enough that I think I can just keep talking. So thank you so much for watching that video. As we shift, let me just, before we move on and dig a little bit deeper into some of the findings, I do want to acknowledge Vivian Hemme and Jasmine Bland, who saw this project through to conclusion. It's not the easiest thing to shoot video during a global pandemic, and they really worked hard to get it done. So a big thank you there. But with that, let me turn over to Rachel Applewhite for a bit of a deep dive into some of these findings. Rachel?
Thank you, Kelly, and good afternoon, commissioners. It's clear the 6 awardees of the NAS investment program achieved substantial improvements in care for mothers with opioid use disorder and opioid-exposed newborns. As mentioned in the video, awardees observed significant decreases in hospital utilization, including need for pharmacologic treatment, hospital length of stay, and transfers to higher level of care. Next slide. These changes were largely shaped by increasing non-pharmacologic interventions centered on family engagement, which was a critical component of the NAS investment program. All awardees noted that the emphasis on these interventions had a positive impact on infants, parents, and staff. Among term opioid-exposed newborns eligible for rooming in, awardees saw an 18% increase during the intervention period. And among opioid-exposed newborns eligible to receive mother's milk, which includes breastfeeding as well as pumping of breast milk, awardees saw a 23% increase. While skin-to-skin contact remained fairly consistent over the course of the NAS investment program, the data shown reflects a high rate overall. Additional analyses show that lower rates of use of intensive care settings and pharmacologic treatment were seen among opioid-exposed newborns that received non-pharmacologic treatment or interventions, and similar patterns were seen for hospital length of stay for opioid-exposed newborns. Next slide. Behind these results is also incredible learning about many aspects of care for families impacted by opioid use disorder. Providing additional support services and social resource connections was particularly important for this population, as women face numerous barriers to engaging in both their own medical care and care for their infant. A key goal for awardees was to engage mothers as early as possible prenatally and provide additional support post-discharge by expanding wraparound services such as patient education, recovery support, and resource connections and referrals. They even hired new staff in outreach and support roles like social workers and peer moms and recovery coaches. Additionally, the HPC funded an outpatient program, Moms Do Care, at Beverly Hospital and Lowell General Hospital, which aims to expand medical and behavioral health service capacity to engage and retain pregnant and postpartum women with opioid use disorder and trauma-informed and integrated healthcare, addiction, and recovery services, including medications for opioid use disorder. And findings from our program found that women who engaged in medications for opioid use disorder and comprehensive treatment had a greater ability and likelihood to engage in non-pharmacologic interventions for the care of their newborn, which we know are extremely important. Next slide. The NAS investment program aimed to promote respectful patient-centered care through the recovery and birthing process by creating changes in staff attitudes, as well as adoption of best care practices and protocols. While, of course, the NAS investment program was time limited, it still created changes that extended beyond the grant period. As you can see on this slide, these changes span from organizational culture and adoption of hospital policies to decisions about resource allocation and sustaining care models. Some examples include training on trauma-informed care, staffing peer moms, and open communication between inpatient and outpatient staff. And on the protocol adoption side, some things that were sustained are rooming in models, breastfeeding guidelines, cutover programs, and wraparound services. In closing, implementing and expanding care models focused on families, mothers, and infants impacted by the opioid epidemic has been a focus for many birthing hospitals throughout Massachusetts. The 6 awardees participating in the NAS investment program produced real and important improvements in care and outcomes for mothers with opioid use disorder and infants at risk for neonatal abstinence syndrome by increasing non-pharmacologic interventions, optimizing pharmacologic treatment, and increasing access to services for mother and infant post-discharge. All the learnings have been the backbone of multiple HPC publications, and I'll hand it back to Kelly to present on those.
Well, before we do, let me ask if there are questions or comments from the commissioners that we can respond to.
Any questions from Mark? Don?
Yeah, wow. Rachel and Kelly, this is heartwarming. What a way to begin a meeting. Have you found interest from other hospitals with neonatal units in the Commonwealth in this program?
Go ahead, Rachel. Why don't you explain the network?
Yeah, so we've worked closely with NeoQuick, which is the Neonatal Quality Improvement Collaborative Massachusetts, and PINQUIN, which is the Perinatal Neonatal Quality Improvement Network of Massachusetts, on a lot of this work. They provided technical assistance as well as some of the quantitative evaluation. And we've supported some of their work through our state opioid response grant and expanding some of these interventions and protocols to other hospitals. So we've supported them in expanding some methods around optimizing farm treatment, like the Eat, Sleep, Console method. And a lot of these hospitals have shared their findings with other birthing hospitals throughout the state. So it really has been a widespread effort.
Okay.
There's actually a very established network among the hospitals through the PINQUIN initiative, where they share best practices and come together, this kind of stuff.
Great. Any other questions or comments? Okay, Kelly.
Okay, so it's back to me. So as we mentioned, as Colleen mentioned earlier, the video is one of a number of NAS related resources that we are making available. You know, we have an impact brief, which is a snapshot of the results, the evaluation report that goes even deeper than Rachel did on some of the interesting findings from this program, and coming soon, an anti-stigma resource guide that aggregates advice, wisdom, recommendations from the 6 hospitals about how to reduce the stigma associated with mothers and families with opioid use disorder. So, you know, whether you're motivated by the stories of the families or by the hard facts, there's a lot of content available, and we certainly hope that people will make use of all of it to continue to spread the word about these important programs. So thank you, Rachel. So with that, I am going to continue with our sort of dual maternal health and a health equity theme, and introduce the birth equity to support. No, you took away the words in front of me, and see if I can remember well. The birth equity and support through inclusion of doula expertise, or BESIDE investment program. So we are here today specifically to seek your approval for our request for proposals, and I am going to invite my colleague Jasmine Bland to review the details of the program and the RFP. Jasmine, take it away.
Thank you, Kelly, and good afternoon, commissioners. The HPC was tasked by the legislature with developing a 2-year pilot program to reduce pregnancy-related deaths and improve pregnancy outcomes. The language specified that we were to develop this program with data support from the Department of Public Health and the Betsy Lehman Center, both of which we consulted with throughout the course of program development. The language also specified that awardees should be selected based on a few things, including community need, capacity to address preventable complications and death, ability to facilitate care coordination among providers, and plan to formalize relationships between providers, including hospitals and community-based care providers. Next slide, please. In our landscape analysis and stakeholder engagement, we confirmed that maternal health is a critical health equity issue, as Colleen mentioned earlier in the meeting. Black birthing people in the United States are 3 to 4 times more likely to die from pregnancy-related causes than white birthing people. These inequities are also reflected in our statewide data. In Massachusetts, Black non-Hispanic women have twice the rate of severe maternal morbidity during delivery hospitalization as white non-Hispanic women. These data are concerning, and there has been some growing attention around this issue, both at a national level and statewide, and there's been an increase in activity. In the state level, we have a new Racial Inequities in Maternal Health Commission, which the HPC does participate in. Next slide, please. Given what we've learned, we're pleased to announce the Birth Equity and Support through the Inclusion of Doula Expertise, or BESIDE, investment program. The BESIDE program takes a racial equity approach to maternal health by addressing inequities in maternal health outcomes and improving patient experience for Black birthing people by increasing access to and use of doula services. The BESIDE program has 4 goals that are listed here. The first is to increase the number of Black birthing people who have the opportunity to work with doulas. Given that this is a health equity program, we have a particular emphasis on these doulas reflecting the patient population that is served. Through this doula support, we hope to see improvements in prenatal, labor and delivery, and postpartum care for Black birthing people. Our third goal ties into something we heard several times in our stakeholder engagement, which is that not all clinicians are completely familiar with the doula role and the scope of doula responsibilities. BESIDE aims to support the development of a culture of understanding and mutual respect between doulas and the clinical and administrative staff in the program. And our final goal here relates to something I've already mentioned a few times, but deserves to be called out explicitly. At its core, BESIDE is a health equity and racial equity focused program, and we're looking for the initiatives to fully embed principles of racial equity and cultural humility in the design and program implementation. Next slide, please. So pursuant to the legislation I previously mentioned, the HPC will invest up to $500,000 in these initiatives, making available up to $250,000 each for no greater than 2 eligible entities. As a reminder, eligible entities for the BESIDE investment program include Massachusetts birthing hospitals and birth centers. Awardees will enter a performance period of 24 months, comprising a 3-month planning period and a 21-month implementation period. Next slide. So on this slide, I'll highlight some of the core aspects of the BESIDE program, which some of them are embedded principles and some are specific awardee activities that applicants will need to speak to in their applications. Applicants will need to demonstrate a plan for securing a doula workforce of doulas who reflect the target population. Doula services may be provided by doulas who are employed by the awardee directly or by contracting with a doula organization. We're open to applicants proposing new doula programs with BESIDE funding or enhancing existing doula programs that may exist already within their organizations. While we haven't dictated what specific services doulas must offer through the BESIDE program, we have established some requirements regarding the number and period of services offered to birthing people. So doulas will work beside birthing people in the prenatal period, during labor and delivery, and at least 6 weeks postpartum. In total, awardees will offer a minimum of 6 doula visits per birthing person, with at least 1 in the prenatal period and 1 in the postpartum period. And I'll just take a moment here to quickly emphasize that offering services in the postpartum period is critical and a very intentional decision here, because adverse maternal health outcomes may occur in the days and weeks following birth. And then again, these last 2 principles tie back directly to some of the BESIDE program goals. Again, this is a racial equity center program serving Black birthing people, so applicants must demonstrate an existing commitment to racial equity and take steps to ensure that the values, priorities, and needs of Black birthing people in the applicant community are reflected in the program design. Additionally, applicants must take steps to support the culture of understanding and mutual respect between doulas and clinical and administrative staff, as I mentioned earlier. Next slide, please. In terms of timeline and next steps, all materials will be on the HPC website immediately following the board vote today. And at that point, we can begin to collect and track questions, issuing FAQs until July 2nd. In that time, we also plan to host an information session tentatively scheduled for June 8th. Proposals are due July 20th, and we hope to recommend awardees at the September board meeting. That concludes my slides for today. I'm happy to answer any questions about the Decide program if there are any.
Any questions? Or this sounds like a very interesting project. Is any of this stuff being done in other parts of the country?
There have been some various projects happening around doulas. It seems to be honestly growing excitement around doulas from our stakeholder engagement. There are a few states that have done Medicaid doula pilots. I believe Oregon and parts of New York have done this.
And is there a growing literature about it, or because it would be great to sort of write up some publications, not only for our website, but as we move along, see if you can get some of this information, not only for this one, but also the previous one, into journals which are being read around the country.
Absolutely. There's a pretty strong literature base and evidence base around doulas as a concept, and doulas as a way to support patients. Doulas have been shown to decrease cesarean rates and otherwise improve a lot of maternal and infant health outcomes. So there's a lot of literature there, but we are excited to learn from this program and learn throughout the course of the program more about doulas and put more of that kind of information out into the world.
Right. Tim, you have a question or comment?
Yeah, just a quick question. This is a really great presentation. Look forward to the proposals. Do you have an expectation of how many grants would be awarded or how many awardees there'll be at the end, or is there a range that we're looking for?
We're expecting to award 2 grants.
Thank you.
Okay,
any other questions or comments? Don?
Yeah, thanks. I was going to ask what Tim asked, but so it looks like you've decided to have you do $500,000 grants. And my question is, what did you? I trust your judgment, but wondering what thought through maybe a larger number of smaller grants might achieve it, or did you cross this out as really requiring that amount? It's a great program. I'd like to see as many as possible.
Thank you. The legislative appropriation was $500,000. So it's 2 grants of up to $250,000 is what we went with.
And have you had any, have you got a theory about what it would cost to do the program? You think it would cost $250,000 to set one up on a single site?
So we're hoping that the bulk of that is going to providing services for birthing people. It's part of the application, part of the operational response template, kind of speaking to the budget in a little bit more detail of how that would be spent.
Thanks, Jeff.
Mary Lou?
Yeah, so I'm a little confused because we have doulas in the Commonwealth of Massachusetts. So what is exactly the goal of the 2? I mean, it's sort of a follow-up to Don's question, like why the language does not preclude just 2, and $250,000 is a significant gift for a limited period of time. So why is it we're just anchored to 2?
So
I think we're following up on, I think where Don was, like, what's the?
Yeah, part of the reason that we opted for a smaller number of doulas and a smaller number of awards and larger award amounts is that what we heard consistently in stakeholder engagement was that one of the big challenges to increasing the rate of doula utilization among Black birthing people was simply paying the cost of doulas. So our thinking was that $200,000 would not largely go to infrastructure at the awardees to run the programs, but that a fair amount of it would go to actually funding the provision of doula services. And we wanted to make sure there were adequate resources for that.
May I just follow up, Stuart?
Sure.
Then it would seem to me then you would want the services in a greater number of places where women of color give birth with doulas.
Yeah, I mean,
then it's very confusing to me why you would limit this to 2.
so our intention and a component of the request for proposal is a demonstration that the organization that's seeking the award does serve a meaningful proportion of Black birthing people. So we've done the research, we're aware of what those organizations are. And our intention is to prefer those organizations specifically.
I think you're limiting yourself. My comment.
Okay, we can certainly take that feedback and consider adjusting the number of awardees and the amounts. I think if the substance of the program is resonating and we should reconsider sort of the allocation of dollars, that's certainly something we can do. We can consider.
Kelly, are doula services covered by Medicaid?
Not
No.
This time.
Not currently. We're planning to include it in our 1115 waiver.
Thank you.
We're considering including it in our 1115 waiver.
Other comments or questions? All right, well, yeah, it sounds like taking a look on whether you could reduce the amount and increase the number of awards may turn out to be a good thing. It would broaden the scope of the activity and get it into more places. All right. Why don't we go ahead?
Well, I was just going to say, we're just asking for a vote to be able to release the request for proposals.
Yes,
today.
I was just about to say that. Thank you.
And Stuart,
all right.
I'm sorry, before we do that, let me just ask Kelly. Kelly, will you still be able to make this timetable given the discussion that we just had about rethinking the amount and the number of grants? Will this timetable still work?
Yeah, I think so. I mean, I think it's the substance of the RFP is done. Changing the number of awardees is pretty straightforward.
Okay, thank you. That's all I wanted to know.
All right, good. So, well, we can approve this subject to rethinking whether the possibility of increasing the number of awards.
Yes, absolutely.
Okay.
So the motion is up on the screen. I won't read it for you today, but if there is a motion.
I'll move.
And a second.
Second.
Thank you. Okay, I'll start with you by roll call, Mr. Chairman.
I support it, yes.
Vice Chair Cohen.
Yes.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Yes.
Commissioner Foley.
Yes.
Commissioner Kreider.
Yes.
Commissioner Master Giovanni.
Yes.
Commissioner Roeder.
Yes.
And Secretary Sutters.
Yes.
Thank you.
Okay. All right. Colleen, we're now going to move the program along to focus on the market oversight and transparency activities.
We're keeping you on your toes today, Mr. Chairman, because now David Zeltz will take over.
Well, I'm about to give it to him.
Thank you, Colleen. Thank you, Mr. Chairman, and thank you, Kelly, Rachel, and Jasmine for those great presentations. So for the second half of the meeting, we're going to shift focus to the HPC's research and market oversight responsibilities. So first up, I'm pleased to turn the agenda over to David Auerbach and Diana Sanchez, who will be presenting on one of the topics to be included in this year's upcoming annual cost trends report. Historically, this signature research report from the HPC is usually released in the first quarter of the year. But however, this year and in years moving forward, the expected release of this report will shift to the summertime. And this is a change that's reflective of CHIA's new timeline for requiring payer reporting and the new timeline for their production of the annual report, which now shifted from the fall to the spring. So for today, David and Diana will present a portion of the upcoming report on a very specific topic. And we very much look forward to your feedback, input, questions, and policy reflections as we seek to incorporate these findings into our final written report to be presented at the upcoming July board meeting. So with that, I will turn it over to David and Diana. Thank you.
Okay, thank you, David. And hello, everyone. I'm going to be presenting this along with Diana. I'm going to present about the first half, and then I will come back in at the end. And this is work the research was undertaken by Hannah James and Diana Sanchez, and with support from Laura Nasuti throughout. And so what we were interested here in is understanding the experience of lower income commercially insured residents in Massachusetts. We've had some hints of difficulties in affording care, of difficulties in access through some of our prior work, and we wanted to do a deeper dive on that. And so part of the background also that I'm noting here is that prior study, some work by the Attorney General's office in 2016 and undertaken by Mass Health regarding the ACOs have found lower spending among lower income individuals, somewhat unintuitive. And we wanted to understand, really that was part of our motivations, to understand what's happening, what is causing that lower spending. Is it difficulties in access of care? Is it about avoidance of care? It really was unclear. And so we're taking a two-pronged approach and using two different data sets in this work. First of all, we're going to be examining the Massachusetts APCD, and we'll look at trends in spending and use of care by, we don't know the individual's income, but by the zip code from and where they live, and grouping members and patients in that way. And then we're going to turn to CHIA's Massachusetts Health Insurance Survey, which is a survey of about 5,000 individuals they undertake every 2 years, to understand directly from the individual's subjective responses in their care patterns to get more at an understanding of what we're seeing in the spending data. And we'll also be using a recontact survey where, along with CHIA, HPC designed a follow-on survey for those individuals in 2019 who noted challenges in affordability or with avoidable ED, and ask them an additional series of questions, which we're going to be showing you the results for. They're very, very exciting and novel results. Okay, let's go to the next slide. Okay, so first of all, to orient you to these slides, we'll be showing, we generally divided up the population of folks in the APCD by their zip code, the income of their zip code, and we're grouping them here into quintiles, the lowest income on the left and the highest income quintile on the right. Sometimes we'll be using deciles and dividing them into 10 groups and so on. So the top line finding here that is confirming what some of those other studies have found is that we also see lower spending for the lower income folks on the left than the higher income folks on the right. You're looking at overall spending in the blue bars, and this is spending, both out of pocket and paid by the members' insurers combined. And then in the gold bars, even if you limit to the population that has at least some medical spending, it's pretty much the same trend, and that's a difference of about 11% across the quintiles. Okay, next slide. And this next slide is showing, as we segmented that out, one thing we wanted to look at was, all right, lower spending for lower income people. Why is that? Well, one thing that you find is that part of the reason is because the lowest income people from the lowest income areas are more likely to have no spending at all. Zero medical spending. About 16% of them just have no spending at all. And we don't think this is because they're healthier. I'll show you later that the health status doesn't differ. Just a higher proportion of folks are just having essentially no interactions with the healthcare system at all. Okay, next slide. Then we looked at the types of spending incurred by these individuals. And here in the blue bars are the folks in the lowest income quintile, and the orange is the highest. So we're contrasting the two extreme quintiles. And you do see some differences in the patterns here. folks in the lowest income quintiles have more spending, a higher share of their spending for prescription drugs, on inpatient care, and on emergency department care. Whereas in contrast, higher income folks have more of their spending in the outpatient and in professional care. So that was suggestive to us right away that there could be something going on, and other research and literature supports this, that we have a different pattern of spending that looks like we have perhaps less use of office care, less use of preventive care, just less ability to use care at the right place at the right time for lower income folks who might be then ending up in the hospital or the ED. Okay, next slide. Another hint in that direction is we looked at specifically preventive care visits. What percentage of folks had any visit at all of preventive care? And you see again this pattern, higher likelihood for the higher income folks. Okay. Then we took a deeper dive at the ED visit rates, which we already saw the spending was different. And you see again these marked differences. Lower income folks in the blue, almost double the total ED visit rate, even a higher proportion, a higher disproportionality of avoidable ED visits, which we have seen in other data before. And keep that in mind, we'll come back to that in the survey data to understand this finding we've seen before and really didn't know exactly where it was coming from, and even higher mental health ED visits. Next slide. Here we're breaking out again into the 10 income deciles and showing a couple of things at the same time. Just repeating that same pattern of professional spending in the blue. As your income gets higher, more professional spending. And yet inpatient and ED spending goes down. So you see this widening gulf across the graph. And then we're just showing in contrast, the average risk score, which is a way to measure your health status, is really not explaining the trends that we're seeing here. And the next slide. So to conclude from this portion of the data, we confirm we also do see fewer healthcare expenditures for lower income folks. And an important side note is that despite the fact that they are incurring less spending, lower income folks are not benefiting from that in the way of lower premiums. The premiums are the same. And in fact, Chia has found that employees in lower wage firms contribute more, a higher percentage of that premium, versus what their employers contribute to both single and family coverage. So they're not benefiting at all. And in fact, they're in some way faring worse. These differences in patterns, going back to the spending patterns, suggest that lower income residents may be less likely to make use of effective routine care that can prevent longer term hospital and ED visits. So, but to understand if that was really true and what was behind these patterns, we're now looking, I'll transition to Diana, who will explain our work in the Mass Health Insurance Survey to see if there are hints there that can explain these results with looking at, for example, access to care, affordability of care, and avoidance of care.
Before you go on, David, can we say anything about the difference between utilization and prices?
Yeah, that's a great question. It's hard to be super precise about that, but we did, going back to that first slide where we had something like a 12% difference in total spending, we did parse that out into the average price paid for a regular physician office visit by these same income groups. And we did find a trend that the higher income folks were paying higher prices for office visits, but it was not as high as this full difference. So it was maybe half to a third of the difference seemed to be explained by higher prices. But that's a good point. The AGO also pointed out that prices were part of the story, but it doesn't seem to be all of the story.
Yeah, well, it's one thing, but when, for certain things like drugs, then maybe everyone's facing the same drug pricing.
Yeah.
But for hospital and for physicians, it matters where you go, how much the commercial insurer has to pay. So,
yep.
Okay, so your general conclusion is that these spending patterns indicates utilizations differences, even though not all of it is utilization difference.
Yeah, We're telling mostly a utilization story here.
Okay.
Yep.
David, if I could ask, do we see where deductibles and copays play into this? I know you showed premiums.
Yeah, we will come to that in the next
Okay.
section. That's right.
Thanks.
Yeah.
Don?
Question. So David, this is important. I don't want to slow you down, but just to be clear, you're using zip code income levels as a surrogate for individual income.
That's correct.
Okay, so one would expect that to be somewhat dilutive, that lower income individuals might, or I guess more likely, have a more vivid difference.
Yes.
Is that right?
Yes, it is. It definitely is diluted. And in the next section, fortunately, we actually have real data on the individual's own income. So we'll see the undiluted results in that way. Yep. Okay, shall we move on? Great.
Okay.
Let's go to the next slide. Okay, are you all set, Diana? There you are. Okay, take it away.
All right, thank you. My Zoom froze for a second. So good afternoon, commissioners. Thank you so much. So now I'll be sharing about the results of our analysis with the MHIS. So just for some background, we looked at the responses of 2,188 commercially insured adults aged 18 to 64 with 12 months of continuous coverage as of the time of the survey. And we grouped these survey respondents into two groups, a higher income group and a lower income group based on their self-reported income. And those higher income and lower income groups are relative to a cutoff of 400% of the federal poverty level, which for reference is $103,000 per year for a family of 4 in Massachusetts. Using survey weights, we're also able to estimate the population size for these income groups, with the lower income group representing about 850,000 Massachusetts residents, and the higher income group representing about 1.9 million Massachusetts residents. And looking here at the characteristics of these two income groups, we see that adults in lower income households were more likely to be people of color, with fewer identifying themselves on the survey as white non-Hispanic when compared with those in higher income households, as well as to have less education, with fewer reporting that they have a 4-year college degree compared to those in higher income households. But similar, to what we saw in terms of the average risk score in the APCD results, adults in both income groups were similarly likely to report good, very good, or excellent health status, or to report having at least one chronic health condition. Income groups is average income. Those in lower income households averaged about $54,000 per year, and those in higher income households averaged about $167,000 per year. Next slide. Great, and then, so turning towards those 3 different dimensions that David talked about, differences in access, affordability, and avoidance of care. Here we're looking at differences in access and looking at traditional access measures, including having a usual source of care, an appointment with a doctor specialist in the past 12 months, and being able to get an appointment at a doctor's office or clinic as soon as one was thought needed. And for each of these measures, you can see within the parentheses the percentage of lower income adults on the left and the percentage of higher income adults on the right who report that experience. And overall, we see that adults in lower and higher income households were similarly likely to report having a usual source of care and a recent doctor's appointment. Next slide. And so if differences in access don't really get at differences in use that we see, now we turn towards the dimension of differences in affordability. And here in this exhibit, to the left-hand side of that vertical dotted line, we have 4 affordability issues that our sister agency, CHIA, has looked at in their analyses of the MHIS, and on which they recently released a series of briefs about. And those four affordability issues are medical bills being paid over time, having problems paying medical bills, having a high share of family income on out-of-pocket spending, and any unmet health care needs for family. And to the right-hand side of that vertical line, we have the percentage of low income adults and higher income adults who reported lower income adults, nearly 60% of them were more likely to experience any of these affordability issues than those with higher incomes. Next slide. And so diving into the affordability issue of having problems paying family medical bills, the MHIS lets us dig a little bit deeper into the services that resulted in difficulty paying medical bills. And we see that for adults in both groups, medical tests and surgical procedures were the most common services that resulted in these difficulties. But it's important to note that for each of these services, lower income adults were more likely overall to report that they resulted in difficulty paying medical bills, whether it's prescription drugs or emergency care, ongoing treatment, or the like. Next slide. In addition, lower income adults were much more likely to go without needed health care or prescription drugs due to cost. So here on the left-hand side, we have two pie charts which show the percent of adults in each income group who reported that they went without needed care due to cost. And we see that 31% of lower income adults and 23% of higher income adults reported doing so for these income groups. And here we're also able to dig in a little bit deeper into the types of needed care foregone due to cost. And so we see that lower income adults were more likely to forego doctor, specialist, prescription drug, or mental health care compared with higher income adults. And we're also more likely to forego needed dental or vision care than higher income adults. And this could be attributed to some insurance plans not offering adequate dental or vision coverage or not offering it at all. Next slide. In addition, we see that adults with high deductible plans, regardless of which income group that they're in, were also twice as likely to go without that needed doctor, specialist, mental health care, or prescription drug care due to cost, compared to those who are not on a high deductible health plan. And if you look at that bottom pair of bars, where we zoom in on those adults who both have a high deductible health plan and are lower income, we see that those who identify as Black, Hispanic, or other multiple races were more likely than those who are white to report that they went without that needed health care prescription drugs because of cost. Next slide. And so seeing these differences between the income groups in terms of going without needed care because of cost, we examined additional reasons why adults might avoid care. And we see that lower income adults, many of them, nearly 51%, avoided care because of copays and co-insurance, and particularly because the copays or co-insurance were too high, more than the 33% of higher income adults who reported that experience. In addition, lower income adults were more likely to report a lack of confidence that needed care would be covered. So 56% of lower income adults reported having a lack of confidence that specialist care would be covered. And 76% of lower income adults reported that if they needed emergency care, they would choose the ED over urgent care because they're sure that their health insurance would cover an ED visit. So now a little bit more about the differences in unexpected medical bills between these income groups, as well as the consequences of avoiding this care.
Thank you, Diana. And I'll just finish out the last few slides. Let's go back to 42 for a second. I just want to note that this phenomenon of lower income folks being unsure that care would be covered as a reason to avoid care, it makes sense. And we found a separate part of the survey residents were asked how likely, well, they were asked, did you experience an unexpected medical bill in the last 12 months? And that doesn't necessarily mean a surprise out of network bill, but a bill they didn't expect. And 55% of low-income residents said, yes, I experienced an unexpected medical bill, compared to 39% for the higher income folks. So it's quite rational that, you know, if you have low income and you're considering taking on a medical care encounter, that not being sure if that's going to be covered and not being sure what the financial consequences of that episode might be it can be quite daunting and leading to an avoidance of care. And so going on to the next slide, one apparent consequence of this problem, what we've done here is divided the sample into 4 groups in this slide. On the left in the blue, you have lower income individuals in both of those sections. And then we further subdivided the sample top to bottom by those who went without needed healthcare due to cost on the top, and on the bottom, those who did not go without needed healthcare due to cost. And then once we had each of these 4 separate groups, then found out how many told us that your last ED visit was potentially avoidable. And we were kind of shocked by this result in the top left, that it's really more than double all the other groups. 2/3 of folks who both had low income and said they went without needed care due to cost said, yes, my last ED visit was potentially avoidable. And it's really a striking finding that even going back to the very beginning where we showed those differential rates in avoidable ED by income, says to us, this isn't just an income story. It's not just, you know, I'm lower income, I don't really know how to use the healthcare system, but it's about being low income and going without care due to cost. I'm avoiding care, I'm wary of it. My healthcare needs might exacerbate and build up, and I end up in the ED when I didn't have to be. And so that was an eye-opening finding for us. Okay.
David,
Yeah.
can you help me? I looked at these slides and I wasn't sure whether the populations between the first set of slides and the second were the same. The first set you said were commercially insured.
Yeah.
That would not include the Medicaid, would not include uninsured.
That's right. That's right.
Does this new set include everybody, or is it still the commercial?
Still the commercial, but both sections is still the commercial.
I'm really, okay, so we don't have none of this information includes the uninsured or Medicaid population.
That's right. I mean, we could have looked at them, but in this study, we wanted to focus really on those with commercial insurance.
All right, well, that's important. I understand that that's important.
Mm-hmm.
But we have to understand that that could be so you could have, if you were to look at the total low income population and the total high income population, they can have a very different mix of commercial versus other.
Yes,
so dealing
absolutely.
with a smaller, I suspect, subset of low income population than high income.
Yeah, I mean, as Diana said, represented in this half of the presentation is about 900,000 Mass residents are in this low income group, and about 2 million are in the high income group. So we're talking about you know, half of the state's population basically represented in the orange or the blue in this study.
Yeah, but the
differences in income are not as great if we had included Medicaid. That's right.
Absolutely, and the uninsured even more.
Yep, that's right.
But it would have a difference in terms of co-pays.
Yes,
I'm
that's
assuming.
right.
Well, if you're uninsured, the copay is 100%.
But if I'm talking about, if you put Medicaid in here, Stuart, it's very different.
And then you got the opposite on Medicaid. No, I like that. That's why I would like to see it with all 3 categories. So you got Medicaid with no co-insurance and uninsured with 100%, and then you got the commercial with a mix.
Right. We could do that in later work.
I would think that would give you a very interesting
story.
Sure. We could. That's right. Okay. We want it to be more of a homogeneous group here. but still we see pretty big differences. Okay, so there's just one final slide, but I'm certainly happy to have any discussion and further questions. Here are the key findings. So from the first section, as we saw, there was lower total spending incurred by the lower income folks with commercial insurance. And of that spending, more of it was for inpatient care, ED care, and drugs. Less of it was for professional and outpatient care. And the findings from the second half suggest that this is more of a story about avoiding care than anything else. We saw lower income residents were more likely to have affordability issues of all types. And a big reason for the medical bills that folks face is medical tests and surgical procedures. And I do want to note that in our cost trends report coming up, we will talk about some of those unnecessary medical tests and procedures, low value care, as we do every year. And then as we looked further, we found that lower income residents were more likely to be avoiding care, to go without needed care because of cost, and also because of uncertainty that their care would be covered if they sought out an episode of care. And that is related to then higher avoidable use of the ED. Okay. And so are there any additional questions? And I appreciate the discussion so far. We have additional follow-on work already to look more into these issues.
Okay, questions? Comments?
Stuart, can I ask a question?
Absolutely.
So, David, you pointed out a couple of things that I think are just really important. One is just an observation that I've heard stories that people are not going to get their vaccinations because everything in medical care comes with hidden surprise bills. So therefore, why should I trust that even though they tell me my vaccination will be free, it's actually not? And that's just a huge, I think, just a terrible situation. But I want to ask you, so you pointed out this thing, which is very important, which is that employers, they sort of offer the same plan to everybody, but higher income people tend to use the more expensive settings, the MGHs, MGBs of the world, and so on. And yet the premium for the low income population, it's not reflective of the fact that they use lower priced settings. Is there something that we could think about other than do you guess that employers know that they're sort of purposely transferring from low income people to high income people, or that they're just unaware of it?
Well, David, the highest cost is really the emergency department for a lot of care. So it's not clear to me that if you include the real costs of running an emergency department and the prices they will charge for those who can pay it are really quite high. So I think you got a U-shape. And so I don't know where it adds up.
Yes, but David's right. The total spending, even despite the higher ED visits, the total spending was lower for the lower income individuals. And the easy lever that, not easy, but the more readily available lever employers could pull would be to change the premium contribution and shift that and have it be lower for their lower wage employees. And some do this, but very few. That's something that they could do. But in terms of the overall premiums and having that reflect total spending in a more rational way, that's a great question. And I know that the AGO raised this with their report, and I'm not sure anybody has a good answer to that. These premiums are just you have pools across that span income groups, and how do you make that more rational? I mean, I think some of this work leads to the value-based insurance design, benefit design approaches as well, where you really want low copays for the chronic maintenance care, for the office-based care, just because it leads to better outcomes and more efficient spending, and it can lead to lower hospital and ED use as well.
Marty, I know you had a comment or question.
Yeah, thanks, Stuart. So there's another dynamic here, which is the use of healthcare resources also requires taking time off from work, particularly for preventative care, tests. And for lower income people, that's significant, especially if their employer doesn't provide sick time or other compensation. And so that could be another driver as to why folks then are relying on the emergency room and not preventative care.
Yeah, that's a really good point. And it's something where the specific questions we have on access might not pick that up. I could very well have a usual source of care and answer that question, but that doesn't mean that it's actually convenient for me to use it when I need it. And so I think we do need to continue to understand that level of access.
Tim?
Thank you, Marty. You took the words right out of my mouth about access has a lot of levels to it, and clearly employment and ability to find time to access care is a critical one, not just work, but other childcare needs or all the issues we know that are plaguing low-income folks in the Commonwealth. And my other question, Stuart, you hit on about what was the total number of low-income individuals versus high income in the commercial market. And I like the idea of comparing it where we can to the Medicaid population. And then David Arbeck, you were getting there. I just feel like these findings are really important, and to come up with some policy recommendations or changes or ways in which we can do something about these concerning findings to have an impact so people are accessing the care that they need and to lower the overall cost of delivering it. So I just think we should, as we always look at our policy findings, the key findings of the research, what's the policy recommendations or changes that we would advocate for to address the concerns that are being clearly illustrated here?
Yeah, we absolutely will. And David, maybe you have a comment on that, but I also just want to note that some of these findings, I think, point to administrative complexity, to confusion, and even some of the work we're considering on surprise medical bills and out of network. Many of those issues are just baffling to folks and can be paralyzing and lead to not using the care that you need at the right time.
Any other questions or comments? Yeah, well, following Tim's comment, the commercial insurance industry has never really, I think, put together plans which are income sensitive in terms of their premiums, in terms of their co-payments, in terms of their use patterns. And I think, they could. It would be a little more complicated, but if they had lower co-payments for lower income people, well, we may want to, as we look into the future, make some recommendations back to the commercial insurance plans.
Mm-hmm.
All right. Any other final questions? Thank you, David. These are really interesting. Okay, Colleen, who's going to do it now, since you never told me who was doing what?
I'm so sorry. I'm going to give it right back to David Sells.
Thank you, Colleen, and thank you, David, Diana, and many others for the work on the previous presentation. And thank you, commissioners, for the thoughts and questions. I think, as was stated, we really want to build towards policy recommendations and policy ideas through some of this work. So look forward to continuing that conversation. So for the next agenda item, I'm going to turn to Lois Johnson, General Counsel, and Kate McCann, Assistant General Counsel, who will present new research and findings evaluating the Commonwealth's entry into the Nurse Licensure Compact. So Lois and Kate will review the legislative mandate for this report, the structure of the interstate compact, and the results of our independent research and evaluation as to whether the HPC recommends that Massachusetts join the compact, which would require legislative action. We're very proud to present this report, which is the result of a tremendous amount of work in just the last few months, given the accelerated timeline that was included in the statutory mandate for this report. And we hope that this report is especially helpful and timely for the legislature and the administration as there are continuing discussions about what healthcare policy changes are necessary as we approach the end of the state of emergency. And so with that, I will turn it over to Lois.
Thank you very much, David, and glad to be with you, commissioners. So, as you may recall, back in January, we talked about this legislative mandate. The HPC was required by that recent law to conduct an evaluation in consultation with the Board of Registration in Nursing and to make recommendations about the Commonwealth's entry into the Nurse Licensure Compact. We're going to describe that a little bit more detail, but in brief, the state, if a state adopts a compact, RNs and LPNs licensed to practice in that state can then practice in other compact states without having to obtain an additional license. So the HPC was directed to conduct a number of analyses, including on the experience of other compact states, the impact of the compact on emergency preparedness, on the quality of care, and in particular on the practice of telehealth. So we are very pleased to be able to meet the legislature's tight time frame here for completing that report, which is due by June 15th. And today we're seeking your approval to release the report and provide it to the legislature for its consideration. Next slide, please. So in our approach to developing the report included a number of touch points. We collaborated, of course, with Bourne. We obtained information from them on nurses licensed to practice in Massachusetts, and including on temporary licenses granted during the pandemic. We reviewed available literature, including somewhat limited academic literature, but we also read available reports from other states, articles, and published materials. We consulted with experts and relied, of course, on our in-house nursing workforce expert, Dr. David Auerbach, and his team to analyze both state and national data on the nursing workforce. We also engaged with key stakeholders to get their perspectives on joining the compact, which has been debated for some years in Massachusetts. We spoke with the Massachusetts Nurses Association, with the Massachusetts affiliate of the American Nurses Association, with the Mass Hospital Association, as well as the Organization of Nurse Leaders. And we engaged with the National Council of State Boards of Nursing and spoke with the compact administrators to fully understand how the compact actually works. And with that, I'm going to turn it over now to Kate McCann for more background on the compact and to walk us through the key findings in the report.
Great. Thank you so much, Lois, and good afternoon, commissioners. This slide shows current compact membership status in the U.S. states and territories. Shown in blue and yellow are the 35 jurisdictions, 34 states plus 1 territory, that are members of the compact, and yellow indicates partial implementation to date in New Jersey and Guam. One note with respect to New England, there seems to be potential momentum in Vermont, where the Senate previously passed a bill and is scheduled to consider the House's passage of the bill with a proposed amendment this week. Next slide, please. This slide presents key points regarding background on the compact. I won't review all of these points in detail, but they include, for example, a brief history of the compact development, its governing body, what's required for a state to join the compact, and how to obtain a compact license. Highlighting 2 of those points before proceeding, as Lois mentioned, to join the compact, a state must enact the model legislation. To obtain a multi-state compact license, a nurse must be a legal resident of a compact state. In other words, the nurse's primary state of residence, where they can prove legal residency, must be a compact state. They must satisfy the licensure criteria required in that state and must meet the compact's other uniform licensure requirements, or ULRs, many of which overlap with existing state licensure requirements and which include a state and federal criminal background check, which is not currently required in Massachusetts. And we'll talk about that a little bit more later. So before turning right to the key findings, we want to pause here to see if there are any questions on background or framework.
Any questions or comments of anyone? Keep going, Kate. I'm sure we're going to come up with a few.
Great, thank you. So then let's go to the next slide, please. So looking at nursing workforce characteristics, while Massachusetts has a higher rate of RNs per capita than the US in the aggregate, data suggests that the registered nurse labor market in the Commonwealth may experience slower growth and tighten in the coming years. As shown on this slide, the RN workforce here is older, and the age differences are even greater for acute and critical care RNs. Furthermore, growth in nursing graduates is slower here than other areas of the country. Finally, on this slide, in a 2018 survey conducted by the Massachusetts Health and Hospital Association and the Organization of Nurse Leaders, hospitals reported that RN vacancy rates varied by specialty and geographic region. For example, the highest rates for RNs were in emergency departments, and open RN positions in adult critical care and emergency departments were among those that took the longest time to fill. Next slide, please. The legislation also required an analysis of whether entry into the compact would increase the Commonwealth's emergency and pandemic preparedness. Based on the HPC's analysis, the answer is yes. Joining the compact would facilitate the Commonwealth's emergency preparedness, enabling the healthcare delivery system here to react more dynamically to unforeseen and sudden changes in nursing needs during pandemics and other types of emergencies. During the COVID-19 pandemic, Massachusetts faced significant challenges meeting the demand for nurses, most notably regarding intensive care unit nurses, RNs, and job posting data that HPC obtained suggests that Massachusetts hospital employers had greater difficulty than comparator states. As noted at the bottom of this slide, the compact would enhance the ability of Massachusetts to more readily address staffing needs, particularly for the nurse specialties most sought during pandemics, natural disasters, and other crises. First on this slide, with respect to other states' entry into the compact membership has increased following adoption of the Enhanced Nurse Licensure Compact in 2015, and the participating jurisdictions report benefits to state boards of nursing, as well as to employers and individual nurses. The HPC reviewed the research on the compact and the impact thereof, which has not identified negative effects of compact membership. Finally, other states have acknowledged that the compact can reduce administrative barriers to licensure of qualified nurses, enhancing member state ability to address short-term nursing needs. And on this point, it is generally recognized that while the compact does not increase the size of the overall nursing workforce, it is a policy solution that can help address short-term staffing needs. Turning to the second finding on this slide, the benefits of the compact for individual nurses include the potential for reduced time, effort, and expenditure to obtain multiple state licenses, as well as increased mobility and opportunity to work in compact states as a travel nurse or otherwise. There is evidence to this effect in other states, such as Minnesota and Vermont, where surveys showed strong nurse support for the compact. Available survey data on Massachusetts nurses, though from 2014, showed support for the compact, and a recent survey of nurses highlighted concerns about staffing, which the compact could help address. Next slide, please. In governing nursing practice and nursing education, the Massachusetts Board of Registration in Nursing, or BORN, acts to protect the health, safety, and welfare of the citizens of the Commonwealth. If Massachusetts were to join the compact, BORN would retain its authority over nursing practice and nursing education in Massachusetts, including in determining all requirements for licensure in the Commonwealth and in licensure enforcement. While BORN does not typically issue temporary licenses, BORN processed and issued over 8,500 temporary RN and LPN licenses during COVID-19, which was administratively burdensome. BORN has not identified any issues with the quality of the nurses practicing in Massachusetts with temporary licenses, and fewer than 1% of those licenses have had a complaint taken against them. As previously mentioned, the compact requires that applicants for a multi-state license satisfy the 11 ULRs, Uniform Licensure Requirements. Those requirements, and in particular, the requirement that applicants submit to state and federal fingerprint-supported criminal background checks, which are not currently required in Massachusetts, would help strengthen BORN's licensure process, bringing it in line with the highest regulatory standards for licensed healthcare professionals. Participation in the compact would also improve BORN's ability to communicate in a timely manner with other states regarding nurse licensure and enforcement activities. As has been well documented, COVID-19 has highlighted the importance of and potential for telehealth and demonstrated the need to remove barriers to cross-state practice in order to strengthen the ability of the healthcare system to adapt care delivery modes and respond to needs more flexibly in a post-COVID-19 world. The compact supports the delivery of telehealth nursing practice across the healthcare continuum and across state lines, with potential positive impacts on cost and quality of care. Additionally, because nurse educators are subject to licensure requirements, compact membership may also help address the significant concerns regarding the supply of nurse educators, providing an investment in the future of nursing education. With respect to the first finding on this slide, there is no evidence that joining the compact would have a negative effect on the quality of nursing care in the Commonwealth, and the ability to fill short-term staffing needs and facilitate telehealth could yield positive effects for healthcare access, quality, and cost. Finally, in terms of findings, the compact is estimated to have only a modest fiscal impact and will not impede Bourne's ability to continue its mission. If Massachusetts were to join the compact, Bourne would continue to receive licensure fees from nurses licensed in Massachusetts, except for some revenue collected from nurses residing in other compact states who currently pay for licensure by reciprocity. So I'm happy to turn it back to Lois or answer any questions. Lois?
Sure, just to sum up the key findings. The key findings show really multiple benefits to the Commonwealth of joining the compact for the oversight of nursing practice which in Massachusetts, which is the addition of background check to licensure and greater coordination with other states regarding nurse oversight, as well as for employers with ease of addressing short-term staffing needs and individual nurses in terms of increased mobility and administrative ease in terms of a multi-state license. The compact would enhance the ability of Massachusetts to be prepared for future emergencies and staffing needs, and would facilitate telehealth. So those are the three key highlights. And the report thus concludes with a recommendation that Massachusetts join the compact by enacting the model legislation to join the 35 other jurisdictions and our neighboring New England states. So with that, we're happy to entertain any questions you may have.
All right, questions or comments by commissioners? Secretary Stutters?
So, yep, to put a little context, this language, the joining the compact, was actually in the governor's healthcare bill that was filed, feels like a lifetime ago, but it wasn't all that long ago. And the legislature, in lieu of taking it up, authorized the study that is before you today. So I just want to be, and that may have been said, but I just want to give the context for this. So appreciate the HPC's independent review of this. During the state of emergency, we used our emergency powers on reciprocity on licenses with for out-of-state individuals to work in Massachusetts without any negative impact. So I just want to be clear, like we're obviously, I'm not at all objective about this since I was the one who had suggested we actually file this your bill to begin with.
Okay.
And used our emergency governor's CDA and public health orders to be able to provide for reciprocity during the pandemic. So
I do think it's a win-win. On the one hand, as both Kate and the secretary said, it gives us the flexibility to add nurses when we need them to come in with, and yet it maintains the authority of Bourne so that we're not bringing in nurses who, for whatever reason, lack the status or background that we think are important. So you reduce some of the bureaucratic activities that would require licensure, but you don't reduce the quality standards. Am I correct in that? Because you have to meet the conditions of born. So effectively, you're meeting most of the conditions of licensure.
That's correct, Stuart. And actually, I think in the presentation, there's actually some things that are required of the compact that is actually slightly even higher standard than in Massachusetts.
Yeah, well, but it may turn in the future, we might add others. And the point is that the state does not lose its authority to make sure that anyone who practices nursing in the Commonwealth has standards that we think are appropriate. Okay, David Cutler.
Thank you, Mr. Chairman. So I'm very, very strongly in favor of this. I want to ask one question. I don't know all the facts on this, but someone told me that Massachusetts has a cap on what can be paid for travel nurses, and that this may adversely affect our ability to hire travel nurses, particularly in a pandemic. And I guess, Kate and Lois, did you run across this when you were working on it? And if so, is this an issue we should also think about?
That is not something that we have come across. What we have heard is that across the country, and in particular in Massachusetts, at some points, travel nurses were in high demand, and there were sort of, they came at a premium, and that states were sort of competing with each other to get travel nurses to fill needed areas. And that because Massachusetts was not in the compact, we may have been at a disadvantage because travel nurse agencies more readily place travel nurses in compact states just because it's easier. They don't have to wait for licensure. I haven't heard anything about a cap.
If we could look into that just a tiny bit.
So let me, so there's a regulation that we are very actively working on. I would not tie these things together at all. For exactly the reason Lois said, was actually to prevent basically cherry picking.
Okay, Don?
I have two questions, just for out of interest. I'm totally supportive of this. The addition of the criminal background check, is it automatic that if a person has a criminal background, they cannot be a nurse in Massachusetts? Or is there, it's not automatic? Great.
Well, we don't even have it.
I know, I'm talking about if we sign the compact. I'm interested in that as an element.
No, there's discretion.
There's discretion. Thanks.
There may be for certain crimes like level 3 sex offenders going forward, but otherwise there's some discretion.
Under the compact, there's a requirement to do the criminal background check. There is a felony exclusion, and there's also an exclusion if you were convicted of a misdemeanor related to nursing.
It's automatic, the felony exclusion. Okay, well, the other question we have is for the parking lot. As the state of emergency goes away, I'm aware of some changes now in terms of interstate physician practice through telemedicine, and at some point I'd like to be able to talk about that. We don't have to do it right now, Lois, but thank you for this.
Okay. Other questions or comments? Barbara?
Yes, Stuart, thank you. The compact has been under discussion among the states for over 20 years. Getting to something like 34 or 35 states has taken a very, very long time. And a lot of the issues that were initially of concern have since been addressed as the number of states have grown and experience with the compact has gotten stronger. So I think we're in very good shape to participate in this. I think the benefit to nurses, especially those living along our borders who come back and forth is a benefit. Their cost is declined. The ability for nurses to be more mobile in an environment which allows them to do travel, allows them to do telehealth, allows them to teach over state lines. The requirement is that you hold a license or can practice via a license in the state where your patient is, not in the state in which you reside or in the state which you hold the license. And so this broadens the ability to provide care in a variety of emerging ways that I think will flourish after the pandemic because we've had some experience with them during a crisis. So I'm glad that we're at this point, and I appreciate the Commission's independent review to provide to the legislature. I hope that the legislature can take this and move swiftly at this point to approve the compact. Thanks, Stuart.
Other questions or comments? All right, again,
All right, Stuart, I had my hand raised.
Yes, please, Tim, I'm waiting for you. That's right.
You're waiting for me. I appreciate that. So I think I'm maybe one of the few dissenting opinions on the direction here. Want to thank the HPC and the staff and the researchers always do a tremendous amount of work, and I deeply appreciate it. On the licensure piece, I want to just state what I think I understand, and correct me if I'm wrong, that in terms of the Bourne authority, is that the Bourne authority for licensure is for folks who the patients reside in Massachusetts, or they reside in Massachusetts. They get licensed in Massachusetts, and then they can get a compact license and be able to practice in other states. But that if you're a nurse, say, in any other non-Massachusetts state that is in the compact, that you get certified or licensed in your state, and then you apply for a compact license, and then you can operate in Massachusetts, and that Massachusetts actually does not license that RN. You get a privilege to practice based upon the Nurse Practice Act, so that there would be nurses operating in Massachusetts that are not licensed by Bourne, based upon my understanding of it. So I think it's a really important point, because the licensure piece comes up a little bit. Just on my general approach to this is, I feel like we've raised that there is a potential, and I know there's disagreement on staffing shortage or needs in the future. And I think the report indicates that this is not a solution to our staffing needs for RNs. It's a short-term, fill a void, temporary, crisis-based approach and a patchwork approach. I think some of the conversation needs to be, what are we doing to recruit and retain nurses for full-time work? These are going to be temporary travelers who get paid a high rate because they don't have health insurance coverage. They aren't offered other benefits that a full-time worker would be offered. That's why their rates are high, and they get paid a lot of money because they don't get the other benefits of employment. We just had a report on, as a health policy commission, caring about people being covered by health insurance. That's just one thing I want to flag as well. And I think we just went through it. I know Secretary Sutters led us through that with the great support of the governor through the pandemic. And we were able to grant temporary license to 8,500 nurses to be able to provide care during this pandemic. We just saw the worst case scenario of a crisis and the need to fill in. And our state leadership was able to come together to come up with solutions to fill the need to deliver care and do it very effectively. And so I'm just wondering, I think David Seltz, you started at the beginning about reviewing what we need to keep from our response to the pandemic and what needs to go. And I think part of that could be looking at how we were able to grant temporary license or emergency licenses for that scenario. And then there's only, I guess, one question I have is about the comparator states. One of the facts or one of the recommendations or policy points here was that compared to other states, we were not as effective or didn't have the ability to get travelers to come in because we were not part of the compact. And I guess my question is, were the comparator states folks that had the same number of COVID cases that we did, or is a comparator based upon them being the same size? Like, how is that comparison done to make the determination that we were at a disadvantage to be able to get traveler nurses to fill a staffing need during the pandemic would be just the one question, just to my overall rambling statement there.
I'm going to turn to David Auerbach to talk a little bit about the job posting analysis we did and how we selected the comparators and the sensitivity analysis we did.
Sure. Yeah, this is part of the report, and I know that there weren't any slides specifically showing this, but the report called for an analysis of what was the different experience in Massachusetts compared to compact states in terms of the numbers of job posting, the numbers of vacancies and salaries offered. And we did that analysis with a third-party firm that collects this job posting data. And it was pretty interesting. And as we note in the report, we did find, it's hard to be perfectly causal, but we did find that the job postings for RNs spiked in Massachusetts more than the comparator states. And you might say, well, we had more of a surge of coronavirus in the spring, but even if we compare to like Louisiana or other states that had a similar surge, we had a bigger spike in those postings, and the amount of money offered in those job postings, the salaries also spiked more than the comparison states we looked at, which were Maryland, Louisiana, New Hampshire, and Maine, other compact states. So that was one additional suggestive piece of data that was supporting the hypothesis that it was harder for Massachusetts. And we looked at ICU RNs in particular, and the effects were even stronger, these differences, so that it looked like it was harder for us to fill those positions than other states.
Tim, do you want to follow up at all?
No, he answered my question. Not here to debate.
Okay, very good. Other comments or questions? This was a great report. If we don't have any more comments or questions.
Sorry, Mr. Chairman, Commissioner Blake does have a question.
We're now ready to vote on the motion. And so is there a motion to approve the recommendation?
I'm sorry, Mr. Chairman. I think Commissioner Blakeney just had one more comment.
Okay.
Stuart, I'm sorry, just a point of clarification. This compact does not include advanced practice nurses. It includes nurses practicing in other components, but nurse practitioners, nurse midwives, nurse anesthetists, psychiatric clinical nurse specialists are not included in this, just for clarification.
Well, that's very helpful. That should be stated in the report.
Yeah, I'm sorry, I just realized this earlier. And Lois, I apologize. I know we talked yesterday and I neglected to bring that up. My apologies.
Well, no, thank you for bringing it up.
Yes, we make that clear in the report.
Okay. Colleen, any other questions or?
No, I think I'm seeing no more questions. So I think we're looking for a vote to approve a recommendation to release the report.
So moved.
And seconded.
Second.
Okay.
And I will proceed with the roll call vote, Mr. Chairman.
I support the recommendation and the report.
Thank you. Vice Chair Cohen,
Yes.
Commissioner Berwick,
Yes.
Commissioner Blakeney,
Yes.
Commissioner Cutler,
Yes.
Commissioner Foley.
No.
Thank you. Commissioner Kreider.
Yep.
Commissioner Master Giovanni,
Yes.
Commissioner Roeder,
Yes.
and Secretary Sutters.
Yes.
Thank you.
All right, it's passed, and I want to congratulate the staff for an excellent report. Okay, Colleen.
Okay, thank you so much, Mr. Chairman. So that is, we're about to conclude the public portion of our meeting here. Oh no, I'm sorry. We're absolutely not doing that. We're moving to the next agenda item. Sorry, I went too quickly on our performance improvement plan process. So I'd like to introduce Kate Mills, who are our Senior Director for Market Oversight and Transparency. Kate, if you could take us away into this next segment. Thank you so much.
Great. Thanks so much, Colleen. And very quickly before I turn to PIPs, I'm just going to provide our standard material change notice update, as you see summarized on this slide. We've received notice of 125 provider transactions to date, with formations of contracting entities continuing to be the most frequent. On the next slide, you'll see that we currently have 3 notices under review. We are still reviewing the proposal by Collaborative Care Holdings, a subsidiary of United Healthcare Group's Optum Care business, to acquire the non-clinical assets of Atrius Health. And we've received 2 new notices since our last meeting. First, Wellforce proposes to form a new clinically integrated network, which would reorganize Wellforce's existing contracting entities, the New England Quality Care Alliance, or NEQA, and Lowell General Physician Hospital Organization, LGPHO, and their affiliated ACOs. The new Wellforce CIN would begin representing NEQA and LGPHO providers in risk, quality, value-based, and other population health arrangements with payers. Second, we received notice of a proposed clinical affiliation between Boston Children's Hospital and Cape Cod Hospital, under which Children's and its affiliated physician foundations would provide 24/7 in-house professional medical services, clinical oversight, and medical leadership to Cape Cod's pediatric program. Additionally, Children's would provide certain wraparound services to support pediatric care, and the parties state that they do not anticipate any impact on reimbursement rates or referral patterns. Next, we have also closed reviews of 2 transactions since our last meeting. First, a proposed joint venture between Shields Healthcare Group and Haywood Healthcare, an independent healthcare system serving North Central Mass and Southern New Hampshire, to own and operate a DPH licensed clinic for the provision of PET CT and MRI services to Haywood patients. In our preliminary examination, we found limited scope for spending impacts here. While Shields generally has somewhat higher commercial prices than Haywood's current advanced imaging partner, Alliance Imaging, there are some payers for which Alliance does have higher rates, and overall the volume of services is quite low. So the overall spending impact is anticipated to be pretty low. We didn't review any evidence indicating that it's likely to negatively impact clinical quality or access to care. And second, we reviewed a proposal by Ophthalmic Consultants of Boston, a subspecialty ophthalmic practice of 35 ophthalmologists throughout Eastern Mass, to acquire Eye Health Services, which is another subspecialty ophthalmic practice throughout Eastern Mass. In our preliminary examination, we did find that the transaction would be market consolidating, but there was a limited scope for spending increases. So Ophthalmic Consultants of Boston participates in some payer contracts through MGPO, the Mass General Physicians Organization, and Eye Health Services participates in some contracts through Steward. If Eye Health becomes part of OCB as proposed, it would be increasing Mass General Brigham's market share of ophthalmic services, but most of those services are paid on a standard set fee schedule, so the actual prices that are likely to be charged are unlikely to change. Here too, we didn't review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. And I'll pause there in case there are any questions before I pivot to PIPs.
Any questions or comments so far? Okay, why don't you move on, Kate?
Great. So the next topic that we'd like to discuss is the healthcare cost growth benchmark and how accountability for the benchmark works at the level of individual payers and providers through the Performance Improvement Plan, or PIPS, process. So this is really a continuation of the conversations we had both at the benchmark hearing in March and at April's board meeting. It's also a reminder of the process, since we're expecting to resume that process through the executive session that immediately follows this meeting. And it's a bit of a preview. As Colleen noted, we are expecting to release a brief on the Performance Improvement Plan process in the coming weeks. So this slide should look familiar. This is just looking at the overall performance of the healthcare system relative to the healthcare cost growth benchmark. As a reminder, the HPC, working along with CHIA, has really 2 key intersecting authorities vis-a-vis the benchmark. So we report and monitor on total healthcare spending relative to the benchmark, using an unadjusted measure of total healthcare expenditures, which we see here shown as a per capita growth rate. And then we also look at the spending for individual payers and providers, as the next few slides will summarize. The next slide summarizes the Performance Improvement Plan, or PIP, process authority. We'll go through each of these steps in more detail on the following slides, but just to provide the brief overview. After we set the benchmark in step 1, CHIA collects spending data from payers in step 2 to adjust health status adjusted total medical expenses for payers and primary care provider groups. And then in step 3, as required by statute, CHIA assesses growth in health status adjusted total medical expense, and it applies a bright line test to determine a set of payers and providers to refer to the HPC for further examination. In step 4, we then conduct a confidential, robust, multi-factor review of every payer and provider that is referred to us by CHIA across many different metrics and over time. And in step 5, the board can vote to require a PIP for any payer or provider for whom it identifies significant concerns and for which it determines that a PIP could result in meaningful cost-saving reforms. Finally, in step 6, the entity has to propose the PIP with a maximum implementation timeline of 18 months with ongoing reporting and monitoring throughout. And until a PIP is actually required, the review process and the identity of any referred entities remains confidential per statute. So the next few slides dive into that process in a little more detail, but I'll pause there in case there are any high-level questions about how this process works.
Kate, let me, well, maybe you're going to do it later. There are 2 serious issues about this process that we've run into in the past that really need to be highlighted very early, which makes the whole process very difficult at times. One is that, as Kate is going to show you, the data that CHIA has been giving us is several years old. And although we're getting it closer to us, we have to deal with data that's sometimes 2 or more years old. As troubling as that is, I think the most complicated and difficult is the health status adjuster. We've had real problems with the health status adjuster. It sounds good and it should exist, but some of these health adjusters have really fundamentally shifted the data, either making expenditures that were way above the benchmark acceptable, or and vice versa. And I think we've talked about it for several years on the need to do a deep dive on looking hard at these health status adjusters. Forgive me for bringing them up, but it's imprinted on my brain.
Now that's a perfect point, and actually a great segue to the next slide, which is really diving into CHIA's role a little bit more. And so, as you see in this blue box at the top, and as noted by the chairman, CHIA is required by statute to refer payers and providers to the HPC based on increases in this measure, health status adjusted total medical expense. Now, this measure, total medical expense, is intended to capture all medical spending that goes through the claims system, whether that's paid by the payer or by an individual patient out of pocket. It includes things like pharmaceutical spending, as well as spending at the whole range of different providers, wherever they may be. And payers report in both an unadjusted figure as well as a health status adjusted figure. And as noted by the chairman, the health status adjustment means that essentially there's a risk score for the population that is calculated based on the age, sex, and different clinical characteristics reported in their medical charts. Now, we could do a whole separate presentation just on risk scoring, But for now, I'll just note that health status adjustment is very much impacted by coding integrity efforts. And many entities in the market have been engaging in those efforts. And so we've been seeing risk scores steadily going up at a rate that's higher than what we would predict based on demographics alone. So health status adjusted spending in general is a little bit deflated from what unadjusted spending is. And so the growth rates for health status adjusted spending tend to be less, and the overall level of health status adjusted spending tends to be less. But by statute, CHIA is required to refer on the basis of health status adjusted spending. Payers report this TME data by book of business for all members for which they have access to full claims data. So they report per member per month spending for example, all of that payer's commercially insured patients. They do that all as kind of one bucket. Then they'll do another bucket for each other different book of business. So Medicare Advantage would be done separately. Medicaid MCO would be done separately. Obviously, there are very different patient dynamics in each of those populations. And then this is the TME data that's used to evaluate payer spending. But again, CHIA is required to use the health status adjusted figure in examining which entity should be referred. But payers also report TME data for physician groups with PCPs. And so this provider TME data reflects, again, all the medical spending, but it's for that provider's primary care patients. And they're spending at any provider. So your primary care provider is essentially held accountable for your spending if you go to a hospital, regardless of whether that hospital is in any way affiliated with your primary care provider. But that there isn't TME data or health status adjusted TME data for other types of providers. It's only for primary care providers. So hospitals can never be referred to the HPC under this process. We can get a primary care group, but not a hospital referred to us directly. And this provider TME data is reported separately by each payer. So a provider may be referred to us multiple times because they may have HSA TME growth that's over CHIA's thresholds for multiple payers, or they could be referred just for one contract with one payer where other contracts that meet the size thresholds weren't over CHIA's bright line thresholds. And then as you see at the bottom of the slide, CHIA does use bright line thresholds based on health status adjusted TME to determine who gets referred to us. So first, it refers any payer book of business or provider contract where the HSA TME growth rate is greater than or equal to the benchmark. And then second, it will refer any payer book of business or provider contract that has HSA TME growth that is at least 85% of the benchmark, where that payer provider is also large and also has either unadjusted growth that's greater than or equal to the benchmark. And so this helps to address that issue that we talked about briefly up top about risk score growth. But they'll also do it if a provider has a high baseline level of spending. But importantly, based on the wording of the statute, levels of spending, prices, price growth, unadjusted spending growth alone can't trigger referral. So we do have this really important referral role for CHIA, but it does constrain who can come into the process. I'll pause here because I went over that, that there's a lot of detail in there. I'll pause here for questions.
Yes.
Stuart, it's Don. I share your concern, Stuart, and about the adjustment. Very, very for clarifying the statutory basis here. I've been looking this year at Medicare Advantage all over the country in terms of adjustment, and it's a disturbing picture. Would it be possible for us to work with CHIA to ask a hypothetical question, which is what would happen? What would referrals look like if they used unadjusted TME, just so we could compare those lists and see how much the adjustment is actually changing the referral pattern? Would that be legal or not?
That is actually something that we don't have prepared right now, but is something that we could put together and talk about in the future.
Well, I thought
the statute does mean that referrals can only be based on health status adjusted TME. So we do have the unadjusted TME data. We can see who has unadjusted growth that's greater than these bright line thresholds. But by statute, CHIA wouldn't be able to refer just on the basis of that.
No, but we have in the past looked at both. So as Kate pointed out, the referrals are just based on the adjusted. But when we looked at a number of cases, and we looked at both the adjusted and the unadjusted, which is what gave me pause, because sometimes the numbers were quite different depending on whether you looked at adjusted or unadjusted. So we have that data.
I thought we only have that for the referred entities. Is that not true?
That's what I'm saying.
No, we actually get unadjusted data for all of the groups that meet the size threshold. So we do have that unadjusted data.
But when we've done the scrutiny that Stuart's talking about, we are generally looking only at the ones that CHIA referred. Is that correct, as the commission in the PIP process?
Yes. So we are limited to, we can only do a PIP if an entity is referred to us by CHIA. And CHIA can only refer to us, they have to use HSA TME. They can pair it with other things, but they have to use HSA TME growth. They also can't use level, it has to be growth. But once it's referred to us, then we can look at all sorts of things, but for those entities that have been referred. We do have data about other entities that haven't been referred, and we could talk about who would be referred if that threshold were to change. But that is we would be foreclosed from PIPing anyone who wasn't referred to us, if that makes sense. And this is actually a great tee up to the next slide, which is really talking about the HPC side of the process. So CHIA, as I said, has this somewhat limited referral standard that they have to use. But once those entities are referred to the HPC, then the HPC conducts this much more multi-factored review of performance. And so you see for every single entity that is referred to us, we essentially pull all of the various publicly available data sources that we can. So you see some examples on the left, but I'll say that this isn't even all inclusive. But we look at TME levels rather than just growth. We look at unadjusted TME as well as health status adjusted TME. We look at the risk scores. We look at the pricing information we may have. We look at things about the entity size, market share, their performance in other contracts, their performance in other years, et cetera. And so we then pull all of that information together. And as commissioners know, it generally lives in a giant binder. We'll have to figure out a new way to do it this year when we'll be doing briefings remotely. But we then go through all of those various data points with our commissioners to determine those entities for which we have ongoing concerns and for which we would like to get more information. And so then we have a vote to determine a subset of entities with whom we'd like to follow up. And with those follow-up entities, we then solicit additional information from them, which can include detailed confidential data, like the types of data that you see listed on the right side of this slide. And then once we've assessed all of those data, again, we go to our commissioners, we go through all of those data in depth, and the board can deliberate again to vote as to whether or not to require a PIP if they believe that the spending levels are concerning and that a PIP could result in cost-saving reforms. The next slide is really just a hypothetical example of kind of how this works. So we might be more likely to do a PIP, for example, where an entity not only had the high health status adjusted TME growth that triggered referral, but where we also see high levels of spending and or high price levels and or high price increases, and where there aren't other obvious factors at play that seem to explain higher spending. And again, this is particularly true if we see these trends playing out over time, over multiple contracts, et cetera. On the other hand, as you see on the right side of this, we'd be less likely to require a PIP where an entity's high health status adjusted TME growth, which triggered the referral from CHIA, really isn't accompanied by other indicia that lead us to be concerned. So not reflective of an ongoing trend. It could be that there were just a few outliers in a single contract. And so a provider got identified to us for one contract for 1 year, and there were some high cost outliers, and we can say, look, this isn't an ongoing trend. It may be that there were things outside of an entity's control. It may be that there was a new high cost drug that was introduced that was particularly important to that provider's population. But again, we're really looking for indicia of kind of multiple factors of concern all coming together, all coalescing in order to vote to do a PIP. And the next slide really just kind of steps back from this process a little bit. This is now 5 years of doing this process. So Chapter 224 kicked out the effective date for the performance improvement plan process to 2016. So 2021 marks 5 years of doing this process. And notwithstanding the fact that the referral process does have some key limitations, as we've discussed, and we haven't actually yet required any entity to conduct a PIP, the process really does have some key successes as well, as highlighted on this slide. So first, our experience really has underscored the importance of having that robust multi-factor review process. So we have very frequently found specific time delimited drivers of spending growth that triggered HSA TME growth that was over CHIA's bright line thresholds, but showed that those other indicia that we look at aren't really as concerning. And I gave some examples on the previous slide. Often we've found that spending wasn't similarly concerning in adjacent years or with other payers. And sometimes we've actually found through our process that there are data errors, meaning that the HSA TME growth rate that triggered referral wasn't actually reflective of the actual spending growth. And so the depth and breadth of this multi-factor review process has really ensured that payers and providers aren't being held accountable for spending growth that isn't indicative of a general trend or reflects factors outside of their control. Another key reflection that we've had on the process to date is that the back and forth that we've had with payers and providers under review has been quite meaningful, both to the HPC and to the payer or provider. So we've been able to cut spending data in ways that entities may not have seen before, and do comparisons that contextualize data in ways that those payers and providers may not have thought of before. And so many entities have actually expressed appreciation to the HPC for the insights they've gained about their own performance through the process. And then finally, it's important to note that even in the absence of a PIP, some entities have expressed a willingness to work with the HPC to address spending concerns and specific issues that have come up in our review. So here I'll pause to see if there are any other reflections that folks want to share before I turn to my final slide.
Okay, any questions? Okay. Why don't you move on, Kate?
So the final slide just gives an update on where we are now. So last year, the HPC was following up with a number of entities about their 2016 to 17 spending performance when the COVID pandemic began. So the HPC decided to pause that review process to allow payers and providers to focus on the COVID response. And the HPC now has data and referrals from CHIA on more recent spending performance as well. So we expect that the board will be deciding next steps on last year's referrals, as well as beginning the discussion of this year's referrals in the executive session that will immediately follow this meeting. I did also want to note, addressing the chairman's point earlier about the data lag issue. So historically, there has been a lag of a couple years or more between the performance year and the time that we are generally evaluating performance. CHIA has changed its timelines for data reporting. That does seem to speed up the process by about 6 months. So we are gradually addressing the lag issue as well. And I will pause there to see if there are any other questions before we move into executive session.
Okay. So now we're going to get to the current.
So now, Mr. Chairman, with a vote of the board, we would seek to enter into executive session to be able to review some of the confidential information.
Yes, we have to vote on going into executive session, which who wrote that could.
Yes, absolutely. In order to comply with the statutory requirement that we keep confidential the entities of the healthcare, the identities of the entities identified by the Center for Health Information Analysis under Section 18 of Chapter 12C, it is appropriate for the HPC to go into executive session to discuss the performance of those entities. In executive session, commissioners will discuss the healthcare entities identified by CHIA and determine whether to conclude or continue review of those entities. The board will not reconvene in open session today following the conclusion of the executive session. So this vote that I will call by roll call will vote to go into executive session and will be entered into minutes. Motion on the table?
So moved.
Seconded? We'll start with you, Mr. Chairman.
Okay, I approve.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney. Commissioner Blakeney. Oh, I see you. I'm so sorry.
I'm sorry. Aye.
That's okay. Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Kreider.
Yes.
Commissioner Master Giovanni.
Yes.
Commissioner Roeder.
Aye.
And Secretary Sutters.
Aye.
Thank you. All right, Mr. Chairman, with that, we're ready to close out the public portion of this meeting.
Let me officially thank everyone for joining us. And we look forward to seeing you again, and we will then meet in executive session.
Yes, thank you so much. The next meeting of the board is July 14th. So we'll see you all then. Our committees do meet before then on June 2nd. So please tune in then. All materials are available on the HPC's website. And a reminder, all of our meetings will continue to be held virtually until further notice. So visit our website and Twitter account in the coming weeks for more updates.
Very good. Thank you, Colleen.
Thank you.
And thank you to the staff, but for those who will not be joining us in executive session.
Okay. And we're just going to take a 5-minute break of the board before we reconvene.
Okay.
Thank you.